Assalamu alaikum. Please let's take our seats as we try and start. There is a complaint that they're saying there's a lot of cassava that is left and few samosas. It tells us something of how you're eating. Okay, let's just have a seat. So the program is a bit tight. We're running against time. We'll start. The next session will be moderated by Dr. Abdullah Bajabir. We'll have the keynote speech, guest of honor and the representative, NHIF, and someone from Dr. Omar from Ministry of Health.
Assalamu alaikum wa rahmatullahi wa barakatuh. Once again, we welcome to the KAMMP third annual scientific conference. We appreciate your presence and we do not take it for granted. I'd like to appreciate the special guests who've honored us today, including Dr. Omar Ahmed from the Ministry of Health, Mr. Douglas, Regional Manager, Southern Region NHIF, and Ms. Mumbi, Marketing Officer, Southern Region as well, NHIF. Dr. Qasim Sezen, he is the President of World Islamic Health Union. He's come all the way from Turkey. to represent the union. They are the umbrella body of KAMMP and other Islamic health organizations. So welcome, Dr. Qasim. Also, our keynote speaker, Professor Abdullah. Of note is that he has not been well. He has signed against medical advice from the hospital to come for this because he had promised us that he's going to give us a speech. So we do not take it for granted, Professor. We do not have much other than dua for you and all the work you have done for KAMMP. We really appreciate you. Also, we have our Chief Officer of Health from Lamu County, Karibu Dr. Bakar Badawi, our Chairman and the other delegates. Welcome. So without much further ado, as we await Dr. Khadija Shikeli, our Chief Officer of Health, Mombasa County, and a representative from the Governor's Office. We will start with the first presentation from NHIF by Mr. Douglas. Karibu.
Okay, like that. It would have been better if it's I'm Douglas Owino, Regional Manager, Southern Region, NHIF. Southern Region is former Coast Province, all the counties, the 6 counties in former Coast Province. I also cover Kitui and Makwini counties. My office is in Mombasa, Imara building, 3rd floor. My background, I hold 2 master's degrees. I have Master of Research in Health Geography from the University of St. Andrews in Scotland, UK. I also hold a Master's in Business Administration, Strategic Management from the University of Nairobi. I'm a FISQA. I have a fellowship of International Quality in Healthcare. I know some of you know about FISQA. Yes, I'm a member of FISQA. I'm a fellow there. So I'll take you through the role of NHIF in UHC. Sometimes people talk about universal health coverage. At the same time, they talk about universal health care. I believe you know the difference between the two. For NHIF, we'll talk about universal health coverage. Now, just to take you through the Kenya Health Agenda, which is set through the Constitution of Kenya. You are also aware about global health commitments, the SDG goal on UHC. We also have the Vision 2030, the social pillar that talks about health issues. You are also conversant with the Kenya Health Policy 2014-2030. In our Constitution, Article 26 talks about that every person has the right to life. 43 also says that every person has the right to the highest attainable standard of health. Article 53(1) also says that every child has the right to basic nutrition, shelter, and health care. Our vision and mission, we've just launched our strategic plan 2018-2022, and again we've aligned our vision to focus on UHC. Our vision is to be world-class universal social health insurer And our mission, we intend to achieve this by providing affordable, accessible, sustainable, and quality health insurance through strategic resource pooling and healthcare purchasing in collaboration with the stakeholders. Now, NHIF was started in 1966 to provide health insurance under the Ministry of Health then. Later on, it was transformed to a state corporation under NHIF Act number 9 of 1998. The major objective of NHIF is to secure financial risk protection against the cost of healthcare services for all Kenyans through pooling of resources. We get funding from the employed, like most of you are employed, so every month we get a contribution based on a gross pay. I believe most of you pay the highest amount, which is 1,700. We also get contribution from the self-employed, the informal sector, which they contribute a rate of 500 per month. Currently, our coverage in terms of principal members is at 8.3 million. But it keeps on changing every day because we continue to bring more people on board. That translates to approximately 20 million Kenyans. Our focus is to ensure that all Kenyans have a medical cover. So if we can target about 20 million Kenyans, then in essence we'll cover all the households in the country. And you're aware about the UHC pilot counties, that is Kisumu, Machakos, Isiolo, and Nyeri. We are at about 90% to ensure that they're all covered. Now, our headquarters is in Nairobi, and currently we have 6 regions, where KAMMP is called Southern Region. There's Northern Region, Central Region, Western Region, Nairobi Region, and Rift Valley Region. We have over 60 branch offices, over 30 satellite offices. We are also present in all Huduma centers. Our major partners are contracted healthcare facilities and employers. Now, what is the mandate of NHIF? Our mandate is to register, receive all contributions and other payments. We also make payments out of the fund to declared hospitals, the ones we have accredited. We make payments to them. We set a criteria for declaration of hospitals and to accredit them. We also regulate contributions payable to the fund and the benefits and other payments to be made out of the fund. Most important, we protect interest of contributors to the fund. We ensure that the money we collect is protected, not abused. Finally, we advise government on national policy with regard to national health insurance. Our key processes are to deal with coverage, that is ensuring that everybody is covered as a medical card through registrations, and through that we collect revenue. We also do compliance because employers remit their contributions to us every month. We visit employers to ensure that whatever they deduct is remitted, all of it. Of course, some of them deduct from the pay slips, but they don't remit, so we have to do compliance. And of course, if you don't do that, we are protected by the Act, NHF Act. We can proceed and take you to the court to prosecute those cases. But we try to not go that way. We also administer benefits. We have various benefit structures, which we can explain later if you are interested in knowing what we currently have. We also have, we do surveillance in facilities. We engage our providers and we do surveillance. We visit them to ensure that there's quality. We have various delivery channels through branches, satellites, agency model. Lately, we are working with the Equity Bank. We are using their agents to recruit more people, especially in the informal sector. When you go to get services through Equity agents, they also engage you to ensure that you have a medical cover from NHIF. So we are working with them closely to recruit more people on board. We also conduct stakeholder engagement, that is employers, healthcare providers. We have quarterly meetings with them at branch level, at regional level, in the head office as well. We also ensure our processes are free of any risk. We have a risk enterprise management system. Our strategic intent is to increase value to stakeholders through improving access. We also ensure equity, affordability. Of course, I've talked about coverage, quality, and through strategic partnerships. Now, what is UHC? UHC it refers to provision of all people with access to needed health services of sufficient quality to be effective and ensure that the use of these services does not expose the users to financial hardship. Now, what is the role of NHIF towards UHC? You are aware about the government Big Four agenda, and where we fit in is UHC, to ensure that everyone has a medical cover in this country. Now, what is our role? Our role is to raise sufficient funds for health spending. We do this by lobbying the government to increase funding. We have various programs like Linda Mama, which covers our mothers who cannot afford the maternal care. So we lobby government to sponsor those kind of programs. We also have the programs called Inua Jamii 70 plus, for those aged 70 plus. We lobby government to increase funding so that more of them are brought on board. And there's the program for the orphans and the vulnerables. We also lobby government to increase those kind of programs are fully funded. We also work with the county government to cover the vulnerables in their various counties. And so far we have many county governments that are really covering the people in their counties. The other area we also work on is to expand, I don't know where it is. It's not reflecting. The slide is not reflecting. I can just proceed. There's a problem with the I hope you'll have me some more minutes. Okay, let's use this. Can we use this? Let's put this. Yes, I was here. I just talked about lobbying government for various sponsored programs. I've talked about Linda Mama, Inua Jamii, and others that support the orphans and the vulnerables. We also ensure that we expand prepaid insurance fund pooling through mandatory contributions from the informal sector. I've told you that we engage informal sector, self-employed, to be recruited into NHIF. We advocate for additional funds by county governments so that they can support the needy as well. We also mobilize resources from other external sources. And of course, lastly, we talk about efficiency and reduce wastages. We've talked about financial risk pooling. And again, we pool these resources from various contributors together so that we spread the risk across. In NHIF, we don't talk about any precondition. Whether you have a precondition or not, you are covered. But the risk is spread across board. We have a defined benefit packages for radiology, for diagnostics, and we also do what is called strategic purchasing of health services. Nowadays, when we come to a facility, we sign a contract with you, and we ask you what you can offer. Based on that, what we signed with one facility is not the same one we signed with another facility. So we purchase the services strategically. We also use capitation-based budgets and diagnostic-related groups. We are also advocating for the legal review of the legal and regulatory framework by the government. We advocate for a strong health systems management that is through capacity building in governance and leadership. We also want the government to ensure there's adequate workforce to support the UHC agenda. And of course, we also advocate for efficient supply chain management for the medical supplies, and of course on health management information systems, and we also put emphasis on research activities. That is the end of my presentation.
Thank you very much, Mr. Douglas, for that excellent presentation. We have a technical problem with the question and answer panel, so please just write them down, and then one of the rapporteurs will forward them to the speakers. Please have a seat, Dr. Douglas. I'd like to recognize the presence of Dr. Khadija Shikeli, the Chief Officer of Health, Mombasa County, and Waziri Seth from Public Service. Public Service Administration and Devolution. He's come to represent His Excellency, the Governor. He has sent his apologies, and Waziri will represent him. So at this point, I would like to welcome our keynote speaker, Professor. Once again, thanks for gracing us.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. نعم, alhamdulillah, we are able to be together for the keynote address this morning. I think it's important, first of all, to say what it is that we mean by universal health coverage or even universal health care. It is the provision of health care to all people in a given community. In our instance here, we are talking about Kenya, but I think it's a double-sword age. We are also talking about the Muslim community in Kenya. How can we ensure that we take care of ourselves within the universal health coverage that we are talking about? And it should be without the risk of financial ruin linked with paying for the care. And I think all of you as medical practitioners, you have seen how devastating it can be that somebody is taken ill in a family, and the next thing you know, properties are being sold, businesses are collapsing, and so on, to try and take care of the loved one who has been taken ill. Now, universal health coverage is supposed to take care of that, so that a provision is given to everybody, but also to ensure that it doesn't cause disaster. I think, as you have heard from our previous speaker, it means for us to be able to do that, there has to be some prepayment and pooling of the resources. The vehicle that we are using here in Kenya, of course, is NHIF, that we will be prepared to contribute upfront, ahead of time, and pool our resources together, and that has to be made compulsory. There's no room for, if you wish, you can do it, because if you use that, that's disaster by itself. We should also make an attempt so that we minimize user fees where we can, and particularly for the very, very poor and vulnerable, it should be zero for the poor and vulnerable, and possibly what we call negative fees. Not only will they not pay the fee, they will even be facilitated to be able for them to get the financial aid that they do. This computer of yours is going to fold up. So it's not UHC, I can see. It has to be universal coverage. You have to cover my speech. Thank you, sure. So the provision of the health, we have to be sure, has good quality of service and is available to all. And there should be the combination of financial risk protection with availability of good quality of service at the same time. The poor and vulnerable should be covered from the start. Some people have advocated in the past that you should probably start with the insurance of the formal sector, public servants and others and so on, and then from there extend. That type of pattern is not doable, and it will not ensure success. It should be universal from the word go, so that everybody is covered at the same time. We should start, because of the nature of our environment, by covering against infectious diseases, against maternal and child health, and then roll on to non-communicable diseases, so that we roll on very rapidly to reach that kind of goal. And we should limit payments by those who are affected, they should not be paying at the point of service. Payment ought to have been made previously. And the poor and the vulnerable should have been exempted from the beginning. So you don't hold their title deeds and their cars and their fridges and things because they've fallen sick. Expand health services over time as rapidly as possible, and particularly to cover prevention, promotion, and rehabilitation. These are not very attractive services. They don't appeal to communities. When you say vaccinate all the children, give them good nutrition, you see what people are used to is, if I fall sick, I should be able to get to the hospital, and if I have to be admitted, I get admitted, and I should get the service that I'm looking for. That is health. But we know it isn't. Good example you can think of is Cuba, which is very close to America. Cuba has the best health in the world. All their parameters are so good. Against a very wealthy nation next door, you can actually jump into the sea and swim across from Cuba to the United States. It's that short. And yet, by the time you reach the shores on the other side, they have the worst health service coverage. Their vulnerables and poor are not covered at all. If you go and fall sick in the US, you're in trouble. So they do not provide the universal health care, and their health indices are terrible, even compared to Kenya. So that's not what we mean by provision of health coverage and provision of health service. We should bear in mind, like I said before, voluntary insurance cannot give us universal health coverage, cannot give us universal health care, which is what we are looking at, even at best to be a supplement to compulsory pooling. And when we provide insurance only for the vulnerable, insurance for curative services only, then I think that is double disaster, because it doesn't work. Insurance for these unpredictable high-cost items, particularly for high-cost inpatient care, will not get us to UHC. And I think this is something that we need to bear in mind. Now, I just wondered, I was looking at the theme for the conference, where we are talking about best medical practice, and with the same sentence, we are talking of UHC. And my question is, are these two really compatible? And I'll give you an example. Blood clotting, we all know. Venous clotting, yeah? If it is in the periphery, like DVT, occurring in the legs, or occurring in the arms, or in the periphery somehow. In the good old days, you are admitted for 10 to 14 days, you are given intravenous heparin until the clot dissolves itself. So you're given supportive care to allow it to dissolve. That's not what we do today. The best practice today is you thrombolize when you have such a patient. Within 12 to 24 hours of the clot, you should be able to thrombolize and get rid of it. You use urokinase or any other possible method and literally, chemically chew the thrombus away. On the average, it will take you maybe 3 to 5 days. Not the 14 days we used to have before, allowing the natural process to take on. So, the modern way of approaching it is the best way. Thrombolize in 5 days, but pay 250,000 Kenya shillings. That's a lot of money. If you are going to use that as an example of best practice, it is not affordable. And we will not be able to provide as we should. The same thing when we are talking about, apart from peripheral DVT, when we are talking about central thrombosis, like pulmonary embolism, or like coronary vessel thrombolysis. Again, the same thing. You thrombolize. That's what you do. When you have PE, you should be able, within 12 to 24 hours, maybe up to 36 hours, you should be able to thrombolize that clot. And again, it shouldn't take you more than 3 to 5 days to thrombolize. Much larger, bigger doses of urokinase that you have to use. For those of you, if you're familiar, the peripheral thrombolization, you use urokinase, which comes in small ampules of 5,000 shillings. But for the bigger players like PE and coronary, we are talking about the bigger ampules. Each ampule costs 160,000 shillings. And you're going to use maybe 2, maybe 3, either for PE or for coronary. So just buying the ampule of medicine alone is going to cost you 500,000 shillings. Add to that, because these are high-risk areas, the patient has to be either in ICU or in a coronary care unit if you have one, which we do have at Aga Khan. Now we are talking about 500 to 600,000 shillings. Should that be universal health coverage? We can't afford it. So what do we have to do? And yet we have to provide that kind of service. We go on to dialysis, which has now become a universal service thanks to NHIF. Before, when we used to have on the average 10 to 12,000 Kenyans going to end stage each year, and each one of them requiring to dialyze. And we could only afford to dialyze probably 200 to 300 people out of the 10 to 12,000 people, because each dialysis is 10,000 shillings. Kenyans can't afford that. And then NHIF came our way, and now every Kenyan is entitled to that. It is not yet provided properly, and I think, Bwana NHIF, we have to sit with you, because what they are saying is dialysis, yes, but access to dialysis, no. So now the blood has to come out of the human being to the machine and back. And NHIF says, now how you do that is your problem. I'm only paying for it while it is in the machine. How the blood gets out of the patient to the machine, we don't pay for that. So they don't pay for the catheters, they don't pay for the person putting the catheter, but they pay for the dialysis. It's a long way. It's a blessing that they can do that, but I think they need to go that one more step to become universal. But it's amazing. It's a great idea, but I think it should have caps. We should stop there. Those of us who are providing dialysis know we can't go on with dialysis forever. You clog all the machines unless you keep buying more and more every 12,000 new machines every year. Otherwise it won't work. So we should have a cap of some sort. Previously, we used to tell people, get on to dialysis within 90 days, move on to transplantation. Because if you do dialysis alone, by the end of the year, you have paid for 3 transplants. So it's not a doable thing. It doesn't make good business sense to provide one human with enough cash for him to be able to do 3 dialysis, 3 transplants, but you're willing to do that so long as he's dialyzing. And what Kenyans, being smart, have said, why do I want a transplant if NHIF is not paying for me? Let me stick to dialysis because it's free. So they will dialyze for the next 25 years to come because it's free. And I think NHIF needs to come and reflect on that and say, we will put a cap for it. My suggestion is 5 years. You tell the Kenyan, we give you 5 years. Figure out a way of getting out of this dialysis monster and go on to transplant. If in 5 years you haven't found the solution, we will stop. Or find another exit mechanism. It may sound cruel, but I think that's the way out. Don't allow someone to dialyze for 30 years. And the same with oncology, which again NHIF is paying for. That also should have a cap. so that only those who are likely to benefit maximally should be the ones to get oncological services. I think right now, when everybody is welcome, even when we have advanced cancers that are spread all over, end stage, but because it's free, just do it. And I think that is insane. So again, I'm suggesting, yes, provide, but anyone who wants to go beyond the cap, they find alternate method of funding that side of things. So as we heard from NHIF, in order to achieve universal health coverage for communities, to achieve 100% of universal health coverage, you need to scale up NHIF uptake. And I think they've given us methodologies of how we are going to be able to do that. Each and every one of the counties should also introduce county compulsory levies beyond the NHIF, so that somebody has double protection. Let's put it that way. But how can communities themselves take advantage and provide also additionally something of their own? And I'll give you an example. The government says we should activate community health workers networks, and there are very many of them. The government wants to do at least 100,000 community health volunteers, and who should each recruit 20 households in order to achieve that target. Now, I have put in red what I think KAMMP can do. Let the government recruit the 100,000, but let KAMMP recruit 5,000. Are we able to? Yes. We are 1,000 members. 1,000 members should be able to recruit 5,000 community households. 5 households for each one of us. It is doable. You have it might work. Yeah, so we will help the government to recruit a proportion of what the government intention is. And we should do this for our own sake, for our own Muslim community. And other communities also, the Christian communities, can do the same to try and assist the government. So I'm suggesting 5,000 community health volunteers from within KAMMP and the Muslim sector. Each recruiting not 20, as the government wants, but 5 households. But multiply that, if on a daily basis you're recruiting 5, times 30, that is 750,000 households that we can recruit. That's more than enough. And I think it is doable. We can do it. The government wishes to provide legal reforms to align NHIF to UHC, which I think you heard. Align the NHIF Act to UHC, and then group insurances. But we should also have multi-tier benefit packages as well. Instead of saying everybody pay 500 and you are covered university, maybe we can also have a multi-tier and say for 500 you are covered up to this level. If you pay 1,000, you are covered for a slightly better package. And if you pay 2,000, you are covered for an even better package. I think we should have schemes of that nature as well. Then we have the IRA, which can also improve to increase uptake of private health insurance to cushion the NHIF. The multi-tier benefit packages I've mentioned already, and we should launch segregated multi-tiered packages. NHIF has already talked about digitizing for themselves, which I think is good, moving away from the cumbersome physical, yeah? So, and it has become easy. I told my wife to go and register herself last week, and she did. She went in her car, where we are staying, and then came back in 20 minutes, and she was registered already and came with a card and says, here's my card. Now, for those of us who are doing dialysis, we usually encourage our members so that both spouses cover themselves separately and put the name of the other spouse on it as well. And the reason is because NHIF is only able to provide dialysis twice each week based on stable dialyzing patients. But very often we have patients who destabilize, even amongst those who are dialyzing on a daily basis and so on, then something goes wrong. They develop severe malaria, they develop typhoid, they develop other illnesses, and they now require 4 dialysis sessions or even 6. And NHIF says, well, that's your problem. We are providing 2. You pay for yourself for the others. You can't. Not when somebody did not even have bus fare to come to the hospital, and you're telling him the remaining 3 sessions at 10,000 each, you have to pay for yourselves. The answer is no. We need to provide ways of covering that as well. Now, we have patients, even amongst those who are stable and dialyzing. People are different. You have a thin person, a medium-sized person, and a big guy, where 2 dialysis a week doesn't work. They require 3. Some people require 4. Otherwise, they'll die. There's no point in putting them on 2 dialysis a week while they waste away and die slowly over the next 1 or 2 years. So if they require 3 or even 4, then we find it useful that somebody can use his or her spouse to add the other 2, so that you can now go to 3 or even 4 using the NHIF scheme. And we have negotiated for this, and it is doable, and NHIF has been kind enough to allow that. So there are methodologies of doing things like that. Then, of course, create customer-friendly processes like registrations, claims, so that it doesn't take 3 months to get your claim, and so on. And I think NHIF is doing that, which I think is very good. So, in order for us to be able to do that, you need new UHC financing. To some extent, NHIF has mentioned that to us. But we need to move. This very government of Kenya, at the time of our independence, for the first few years, when we were medical students, when we became interns, the best place to go if you are sick is a government institution. In Nairobi, if you cannot be treated in Nairobi Hospital or Aga Khan, you go to Kenyatta National Hospital. They had everything that the private sector did not have. We never fell short of medications at that time. Reason? 9.5% coverage at that time. And over the years, this dropped to 3. And that was disaster. Because within the first 3 months, we have exhausted the health budget. And then now you have 9 months of no budget. We are moving slowly back towards that. And I think we are now at 7%, moving towards 10% in 2022. The truth of the matter is we are moving back where we were 50 years ago. And I think it's a good thing, but I think we need to do that. Then, of course, what is known as the Robin Hood approach, taxing the rich to look after the poor. Yeah? And follow up the RTGSs of the businessmen and tax them as well. And look at all the mobile money transfers and tax them as well. And have a special levy for people who fly because they can afford airline tickets. Tax them as well. And so on. So there should be. I saw a new concept recently that says tax the sin money. If you have sinned, sanitize that money by paying taxes. Now, to us as Muslims, of course, that is not acceptable, as you know. But that's what the Kenya government hopes to do. So it's okay to sin, and it's okay to steal 40% of the Kenya budget, provided you pay 30% of that 40% back in order for it to look after health. So health systems financing for universal health coverage. What do we mean? I think I've explained that. Where are we now? We are moving back towards where we were some 50 years ago, and I hope it works. And we are moving towards universal coverage. But three interrelated explanations linked to health system financing. One, we have insufficient funding at the present moment, but we are moving towards the 10% which is intended. We are still very heavily reliant on out-of-pocket expenses, which is disastrous to families, as we have said before. And then, of course, inefficiencies and inequities in the use of the little resources that we have. Do you know that 35% of money allocated to the health sector is wasted? Actually wasted. So even if we were to save that wasted money, we can still move several steps ahead of where we are at the present moment by reducing wastages. So, solutions: raise sufficient funds for health, reduce reliance on out-of-pocket expenses, and improve efficiency and equity. We should adopt low-cost service delivery models. I think if we look at our Makueni example, we can learn a lot from that. They were very smart. What they actually looked at was if the lower tier of the health sector, level 1, level 2, up to level 3, the government is providing. So the county government doesn't have to. And then the very high on top, level 5 and level 6, the central government is providing. So you don't have to. Makueni discovered, therefore, all they needed to do is provide level 3 and 4. And they said that is doable. With 350,000 families that they have at 500 shillings each, they were able to cover everybody. It covered the entire county budget. They were able to absorb all the doctors in their county and give them jobs, unlike us here in Mombasa, where we qualified 28 interns and then employed only 2. And then slowly we are absorbing them. I think we took another 2 last month, and we are going to take another 2 in 2 months' time. We are a bigger community here in Mombasa than the Makueni County. Surely we can afford to employ all of them, but provided the community pays for it. Get everybody to pay his 500 shillings and then employ all those doctors, because we can afford to do that. Then in addition to that, of course, we can expand our service. We're already doing that in the private sector, by the way, where by using e-health and telemedicine and by using e-hubs, we're actually providing care. You find, for example, in Aga Khan, we are unable to employ 3 or 4 radiologists on a 24-hour cover. So what do? You employ 1, now we have 2. But what did we do? We linked them to telemedicine, so that somebody works the whole day, but his bedroom is still linked to Aga Khan. So whenever something happens in the middle of the night, an X-ray is taken, linked, and forwarded to him, and then we ring him and say, "Doc, wake up. There's an X-ray we've just sent to you. Tell us what to do with it." So that is doable. You can actually use 1 consultant radiologist for 3 or 4 or 5 hospitals, and they're linked up. We used to do that where I trained for my nephrology in the eastern townships in Canada, where the far end, almost near North Pole, was not covered. So those places had medicine up to ICU level, but they were all linked to us in Montreal. Sometimes we used to discover problems in the ICU before the nurses could discover in those places out there. But they were linked with intercom. So you beep, and the nurse says, "Yes," as I look at number 17, what's happening there? So it was possible to provide consultant cover from 200 to 300 kilometers away. So e-medicine, e-health, telemedicine, and e-hubs can also provide us with the needed people whom we don't have at the present moment or can't afford, but can be done by the few of us who are there at the present moment. I think that's my contribution for today. Thank you.
Thank you very much, Professor, for that elaborate presentation. I think you've highlighted most of the things that we would want to ask in regards to UHC. I think, Bwana Douglas, you should sit with Prof. Hand in hand. And thanks very much for highlighting the plight of the doctors. I remember last conference, most people are not happy with Prof when he talked pro the strike. There was the issue of ethics and all that, but thank you very much, we appreciate that. So without much further ado, I think we'll go to a short Q&A for Professor and NHIF so that we can have the official opening ceremony next. Please make it brief. If there are any other questions, we can probably ask the speakers during the lunch break, inshallah. So any questions? Any questions? Okay, I think Bwana Douglas, this is for you. What is NHIF doing about the payments for surgeries, especially maternity? Number one, CS rates are low, 30,000 for private. Linda Mama rate of 17,000 for CS is almost unimaginable. So do we take more questions, or as you think about this, or are there any other questions?
Thank you. It's a good concern, but there are so many factors at play here. We want everyone to be covered. And one thing that, as medical professionals, that is difficult to cost is healthcare. We need to agree on that. There was a consultative meeting that was being driven by us and Kenya Medical Association. There was a meeting sometimes last year that looked at all these surgical packages. We are waiting for that report to be released, and I think some of you participated. It covered almost all the areas. So I will just request that we wait for that report, because it was addressing all the concerns in terms of the cost. At the moment, there's nothing much we can do until we get that report and see what is the level we can meet in terms of adjusting our packages. We have so many people who need care in this country. And for Linda Mama, you are aware that it is a government-sponsored program for the mothers who cannot afford totally. And just to clarify to you, some facilities are able to offer Linda Mama with whatever they are being given, because they get the numbers, they apply what we call economies of scope. They are able to get so many of the mothers to be attended to, so they can spread the risks. Now, when it comes to CS issues, and this is where we need also to be very honest and accountable as medical professionals. How comes all of a sudden CS has increased? Is it because of NHIF taking care of that? Let's be honest on this. Because if you look at what we pay for CS, it has increased tremendously. It has gone up. But before NHIF introduced those covers, it was very minimal. So again, we need to engage as the key stakeholders in this process to ensure that we also control unnecessary CS. Because most of our mothers and sisters and all that, they'll always opt for a CS as an easy option. So it also goes back to us again. We need to control some of the things. But anyway, in terms of those surgical packages, there's a conversation going on between us and the stakeholders. And I think going forward, because for us to achieve all this, we must sustain the cost. To achieve UHC, we must sustain the cost. So I think in a matter of a few months, we should be able to get that report. And again, just to remind you, Kenya Medical Association is represented at NHIF Board of Management. And one of you, Dr. Jacqueline Kitulu, sits at the board. So all your issues are taken care of. Are we together? Yes. You are well represented in NHIF Board of Management. Thank you.
Thank you. Just to add on to that one, this has been a battle from the beginning. I took advantage to answer the Minister for Health when I was chair of the KMA. He asked the same question. How come in the private sector, cesarean sections go up to 25%, whereas in Kenyatta and the other public sector, it's only 3 to 4%? The answer to that one is you are being cruel to the mothers. You are killing them unnecessarily by limiting the CS. If you look at the global performance, you will see it is 20 to 22%, not 3% as provided by the Kenya government. You are killing the mothers. So it has gone up the same way like in dialysis. We used to dialyze 200 out of the 12,000 patients, and now we are dialyzing all of them. How come NHIF is not asking that question? Why are you suddenly dialyzing everybody? Because the need was there. The need was there. We were killing 12,000 Kenyans every year, and now we are not, thanks to NHIF. So bear with us. We will section the mothers as and when necessary.
Thank you. Yeah, thank you very much. Yeah, but we can also control it when it's not necessary. Thank you. Now, the next question is, that dialogue has been there about the number of CS happening. You saw it in the newspapers. We are spending a lot of money on that. It's a concern. Whether it's a good thing or not, yes, yeah, yeah, I agree. The second question was about chemotherapy for the currently 25K, which is 25,000, which is low. We go back to the same question. I know there are certain things that may not be sufficient. 25, and we may not even agree what is sufficient. But what we are doing as NHIF, we are not forcing any facility to accept that amount of money. We have adopted, when I did my presentation, we have adopted what is called strategic purchasing of services. So we go to a facility, we negotiate with you what you can do with that. And if you agree that 25 is enough, then you sign that contract. So for you to sign that contract, it is you who have agreed that it is sufficient. I am very glad about Coast General, because if you go to the oncology unit at Coast General, I've visited there almost 3 times, and I want to thank Coast General for that. I've visited there almost 3 times, and when I ask the patients there, all of them are on NHIF cover. And we engage the team there. And when we visit there, we engage them. People have an opinion about public hospitals, but sometimes we redirect clients to go to Coast. The ones we redirect to Coast General, they give us very good feedback, and they have never stopped going to Coast General. So we have very many examples, good things that is happening in this country, which we can learn from. People talk about Makweni, but I heard you also to go to Coast General and see what they have done in that facility. The standards have improved, they have embraced quality, even the kind of environment, the wards and all that. So if you can do something like that, we can be able to provide quality services at a reasonable rate. Thank you very much.
Hello. Just one question. I'm Dr. Abdulaziz, pathologist from Aga Khan Hospital, Mombasa. So mine is, I just wanted to have a clarification, and I think it's follow-up to Professor's talk, and it's issue concerning the process. It's like one process is covered and another one is not covered. And I think it's a highlight to the two programs which are covered by NHIF, oncology and the dialysis program. You can see all of them are interrelated with the diagnostic service. Because it's painful, you see a mother with a breast lump, histology which is costing maybe 4,000 has stayed for 1 year because it's not covered. Diagnostic laboratory services, I don't know why so far it's really challenging, and it's really painful to see those patients just running around and they can't get a proper diagnosis because they are limited out of pocket.
Assalamu alaikum. My name is Dr. Riaz Kasmani. I'm an oncologist based in Mombasa. So my question is also to NHIF. Now what we find, at the moment I'm not going to ask about the 25,000 yes or no, but most of these clients are on different kinds of protocols. So sometimes you find that they're on 3 weekly cycles, at times they are on a weekly chemotherapy, so maybe like first week, second week, third week, and that's what constitutes as one cycle. At times when you're trying to treat like acute leukemias, the treatment is totally different, it comes in phases, and it becomes very difficult trying to put all those things as cycles as such. Because for example, if they are on a weekly cycle, and you are giving 6 cycles per client on a year, that means that they are going to have just 6 sessions basically, and then they'll be told that your amount is over. So that sometimes proves to be a lot of challenge because we are not able to give adequate treatment. So I'd like your comment on that. The ideal, probably ideal way of doing this might not be to put it as cycles, but to put it as different protocols and to cover it as protocols. For example, like if you're covering a protocol for CA colon, you know that it's 2 weekly chemotherapy for about 6 months, so those are going to be 12 sessions of chemotherapy. Then we say, okay, we are covering CA colon and this is what we will give you. If you are trying to cover gemcitabine and something which is a weekly thing and there are 6 cycles, so that means 6 times 3, that would be about 18 sessions. If you are covering leukemia, the treatment is almost for 3 years, and each month the regimen is changing totally. Yeah.
First, I would like to acknowledge the presence of dignitaries, Dr. Shikeli, Dr. Omar, Professor Abdallah. And I like this discussion, it's quite healthy. My name is Dr. Swale, I work in Mombasa. Mine is a different approach, or a different angle. And I think NHIF can do that. I think apart from paying for the services, it's high time NHIF also demand on how those services are being delivered. I mean, I can get the service, I need dialysis, but by the time I get that service delivered in that institution or any institution, I get it after 2 days or 3 days. I think those are things that we should also get concerned. There are certain things that are time-bound, certain conditions, like we've just talked about pulmonary thromboembolism, about MI. If you're to sponsor, if you're to cover for thrombolysis, then it has to be given within a very good time. Yeah, I think it's high time you look at the mechanism or looking at the quality of the institutions that you have approved for those services to be given, so that the clients are getting the services. The degree of quality is also looked at. The other thing that I think we are spending so much on curative, and I'm not hearing anything about preventive. What does NHIF, what do you have in terms of primary health care? If you're giving the contract to Aga Khan or to Mombasa Hospital, to Coast General, ask them, what is your arm of primary health care? How are you delivering? What is your strategy from primary health care? I can tell you, even countries like America, where money is not an issue, curative is difficult to meet. Obama had a very rough time in the best economy, because you cannot just deliver curative services without taking care of the primary health care. And I think NHIF has really not looked at this. I mean, I have the money, I'm giving you the money to spend on patients. Now I need to demand what primary health or preventive strategies do you have for institutions before I give you this contract. I think it's high time we move that way.
Assalamu alaikum. My name is Dr. Yunis. I work for Mandera County. My question is to NHIF. I think this is a concern, especially to the young doctors who are newly employed. Previously, when we went for internship, there was a government cover, which of course was not working. Then after that, I think for the last 3 years, the county stopped taking doctors directly from the national government. Now they are employing themselves. That means that the government cover disappears. And then after that, what happens? I'm told the county has to sign an agreement with the NHIF. But when you look at your pay slip, the 1700 is still going. When you come to the facilities, you cannot access the services. And you know, I don't know about the Mombasa County, but some counties, their insurance even, the private insurance that they have is not even, sometimes they default on payment, you end up not accessing any services. So what is the stand of NHIF in terms of those contracts that they signed with the counties? Thank you.
I think we'll take those ones, and then we'll see after that. We're running out of time. Yeah.
Okay, thank you. Let me say something about the issue of oncology. We may have certain cases, unique, complicated cases. If you notice a case which is a bit complicated, requires multiple attention, please pick it with our NHIF offices. There are so many cases like that we review and attend to. Sasawa. Yeah, you pick it with that. And what you need to, the problem mostly with the medical professionals, sometimes the medical report, you talk to yourself. Talk to us. Because some of us are not medical doctors. So try to talk to us in those medical notes very clearly to tell us this case needs some medical attention. Whatever is being done is not adequate enough. And there are such cases which we review and we revise upwards in terms of what we offer for certain unique cases. So when you're doing your notes, talk to us, don't talk to yourself. The other issue which was raised about pathology tests and all that, and I think Professor talked about the same area about dialysis, that we don't, treatment is a continuum of services. It's not a one-off thing. NHIF has been concerned about Kenyans, and we were trying to see how can we come in, even if it is not the whole process. How can we come in? And as we move towards UHC, that is the dialogue we need to have. what are the gaps to address, so that we don't offer part and we give you part which is not helping you and we let you suffer. Is that okay? So we may not offer everything, but that is a dialogue that we need to engage going forward. I was having a conversation with some of you during tea, and I said the only people who can change healthcare in this country, who can drive it, and if you want to drive it, are the medical professionals. You are the people to drive the dialogue and change the whole game, if we have to realize UHC. Somebody talked about, apart from the services, how do we ensure that it's timely delivery of services? That you go for a service, you don't get it the same day. I think sometimes we also demand too much from NHIF. We may not have control of your internal processes of the facilities. As much as we try to do surveillance in those facilities to ensure they have quality and timeliness of services, we may not have full control. The people who have full control are in this room. You are the same people working in those facilities who should partner with NHIF and ensure that we have timely delivery of services. I want to give you an example. I don't know whether somebody here who has been at KNH, Kenyatta Hospital. Anybody around? At KNH Emergency Services, casualty, you've had complaints of patients who stay at casualty for more than 12 hours, waiting for a medical specialist. I want to say it for free, because we are in a free country. Before I joined NHIF, I was head of risk and quality at KNH for about 8 years. And that's something we struggle to address. The specialist who's supposed to review the patient is not there. Where is he? It's Aga Khan, Nairobi West, wherever. The patient is waiting on the stretcher. So what you are talking about has to do with Hazia. A patient is waiting for a service. The doctor who's supposed to look at that patient is still engaged elsewhere. So those are matters that has to do with internal processes that as NHIF, we may not have proper control on them. But I want to assure you that when we get to know such kind of things happening, because some of the patients report to us, we try to address them with the facilities. So we may not be everywhere, but we try as much as we can to address them with those facilities. So the degree of quality of services at a facility, I will say that 90% is an internal issue. NHIF may not dictate so much. Of course, we do our assessments, we monitor, and we can pick one or two issues to address with the facilities. So it depends on us here in this room. Another issue was spending so much on curative and very little on preventive. I think Professor said that we are going back to 50 years when the government was focusing much on preventive and curative. And if you look at the 4 pilot counties where we are piloting UHC, the focus is also going towards of primary health care. So we are headed there. The government has realized that's where to go so that we can prevent most of the things that escalate to the higher levels. So we are headed there. We are going back to where we are. And this is something that is supposed to be driven by stakeholders, including NHIF, the MOH, and of course the medical professionals as well. The Daktari from Mandera, you've asked about the cover. All of us as employed persons, there's a mandatory contribution that you give NHIF. And if you're handing some good figure, like most of you here, you give a maximum of about 1,700. That is mandatory, and it is compulsory by law under NHIF Act. The only persons as a self-employed who are not, they're not compulsory contributors. That's why we go and talk to them to be brought on board. But as an employed person, you give us that 1,700 every month, and you are entitled to a benefit package. If you are keen on some of the adverts that we run, there's something we call super cover, the national scheme. You are entitled to a package under super cover. And actually, it benefits, it was enhanced, kind of, and it covers a lot of things. Now, you may have your counterparts in Mombasa County, Lamu County, and other counties. Their county governments engaged NHIF to provide comprehensive cover, like what we give civil servants, the prisons, and the police service. They come to NHIF, negotiate with us, and tell us what they can pay, and out of that, what we can offer. So that's why you realize most of them get more and above whatever you get under the national scheme. Sasawa? Yeah. But still, without that, you can use your NHF card anywhere, so long as you choose a facility under national scheme. So you can still use it. And again, just to clarify this, most, even private medical cover, for them even to do business with you, they'll ask you, do you have NHIF? If you don't have NHIF, they find it a bit, risky, because they know we take quite a lot from them. NHIF, we are not in the business of making a profit. We are a public interest organization. We don't make profit, but our focus is to ensure that your interest as a citizen of this country, you are taken care of. Is that okay? Thank you very much.
Good morning or good afternoon. I would like to add something more to what my boss has said. There's somebody who had asked about preventative. As part of the packages, it's important for people to know that there's a provision for an annual checkup. Although at the moment, that is only for the principal member, I think there's negotiations for it to move on to principal members as well as other members of the family. So it might be a small drop in the ocean, but there is a provision for people to go for one annual checkup.
Sorry, my name is Dr. Mohammed Salim, based in Mombasa, KAMMP. So I have two, or is it questions or suggestions, I'll say. I had the patient two following. One was a civil servant, one was not. And I had to treat them differently depending on what they can pay. And the one who was not a civil servant asked me, I pay the same as much as the civil servant is contributing to NHIF. They're friends, so they know. I pay the same amount and he pays the same amount, and this is not a civil servant SACCO. It's a national, like an ID. Why is the government giving different to one and different to a civil servant? Number one. Number two is I happen to treat some diseases which I can admit for 2 days, use a device of 1.2 million and discharge the second day. We use around 80 to 100 of those devices in Kenya per year. Unfortunately, out of 1.2 million, around 400,000 is taxed on that. Now, if NHIF, which is the biggest insurance in Kenya now, negotiates with these companies, look, we'll reduce your taxes as the government from Ministry of Health, and we will acknowledge your device to be used by NHIF clients, but you need to come on our prices. We have seen some medications being sold at 2,500, to KAMMP is 800. And yet they still are willing to sell, and they make a profit. So if NHIF says we have this 8 million principal contributors, we'll cater for your device, but instead of selling 800,000, sell it for 500,000. And out of, there are more people who can afford 500,000 than those who can afford 1.2 million. So just a thought, food for thought. Thank you.
I think we'll continue from here, unless you have any comment to that. You have work cut out for you, NHIF. I know you're trying your best, but if we open the forum to questions for NHIF, I also have like 5 or 6 for you, which we'll talk later. But unfortunately, we don't have time on our side. We have a lot of presentations, and we have people who've come specifically for that time, and they would beg to leave after that. So we would like to start officially with our opening ceremony. I would kindly ask NHIF and Prof. We have Dr. Kasim from Turkey, please, to sit on the podium. Professor. So next we'll have Dr. Khadija Shikeli. She's the County Chief Officer. She's the Chairman of County Chief Officers of Kenya. So all these Chief Officers of Kenya, she's the boss of them. Yeah? And she's the County Chief Officer of Health Medical Services, Mombasa County. Karibu.
Assalamu alaikum. Good morning. Good afternoon. Oh, sorry. CCM, Waziri Saith Odongo, Waziri for Public Service Administration and Devolution, Mombasa County, Chairman KAMMP, Dr. Marjan, Secretary General, Dr. Bajabir, our keynote address, Professor Abdallah, my mentor, President of WIHU, that is the World Islamic Health Union, Dr. Kasim, our NHIF representative, Dr. Omar, my brother, who is the project manager for THS, UHC, Ministry of Health, distinguished consultants, specialists, doctors, I hear them, I'm seeing a number of nurses and all other health professionals. Assalamu alaikum tena. Well, I'd like to talk about UHC. I know Professor has already defined it. This is strange. Okay, I'm a bit shorter. But I agree with Professor. We have to look at, there has to be a need. And this needs to be addressed for the whole population, number one. Then we have this need, or whatever the population needs, it has to be there should not be any financial constraint. So we have to reduce the financial burden. And then quality services. That's all you said. And that is the definition of UHC, or universal health coverage. I will start with Mombasa County and then talk about the other counties that are actually practicing UHC. Then we have the Big Four agenda for His Excellency the President, where UHC is being piloted right now in 4 counties. I will leave that to Dr. Omar to do. I think he will talk about it, even though it's in the counties. But Dr. Omar is going to talk about the Ministry of Health and the 4 pilots. For Mombasa, we know all these things, but as you said, I agree. I totally agree with you. We cannot just start it off like switching on a switch. One, we have to prepare for it. And this is what Mombasa is trying to do. We were not in the 4 pilots. We lobbied very hard, but I'm glad we were not taken in. So one, we have to get the facilities ready. That is infrastructure. If you do not have the infrastructure, then we are saying all levels. And maybe a point of correction, health is devolved. So all the levels, level 1 to level 5, is actually the prerogative of the counties. We are fully in charge of all these services. So from level 1, which is community health service, dispensary level 2, health centers level 3, sub-county hospitals level 4, and then the county referral hospitals, which are level 5. Only level 6 is not in the counties, and that is under the national government. Yeah? And I don't know whether you know, but there is a bill now, the national referral hospitals, that actually the national government want to take over our referral hospitals. One is our cost. We are not going to give it off like that, really. And no, really, why does the national government want to take everything after we've done so much? And I thank the representative of NHIF. So what have we done? We have actually tried to, we're building 6 hospitals. One is already officially open and is working. That is the Mrima Maternity Hospital. This is in Likoni Hospital, in Likoni sub-county. I don't know whether you know or not, but Likoni, when we took over in the county, this has been going on since independence. Every woman in Likoni sub-county can only deliver normally. If they needed a cesarean section, they had to go through the ferry, come to Coast General Hospital to have a cesarean section. That's why I think it was 3%. They could not get to the hospitals to get it done. But really, now as we speak, the county government of Mombasa has opened a sub-county maternity hospital fully just for mothers and children in Likoni. The second thing is we have built a theater and maternity wards in the existing sub-county, Likoni sub-county hospitals. And there are 2 more sub-county hospitals. I said 6 hospitals. So these are the new hospitals. They're in Likoni, they're in Changamwe, they're in Kisauni, Nyali. And 2 of them we are opening in May. I think for those who read the newspapers and look at the advertisements, we have actually advertised for the 2 hospitals, recruitment of human resource. I think it was then about 2 weeks or 3 weeks ago in the newspapers. This is the Chaani Hospital, sub-county hospital, that is in Changamwe, and we are opening Marimani. Marimani is nani amekwenda Mwakirungi hapa. That is one of the most rural areas of Mombasa. There was only a dispensary there in Marimani, and we have one in Mwaunguja and one in Mwakirungi. And we have built a sub-county hospital, a 50-bed. These sub-county hospitals are 50 beds. Why are we building them? We want every sub-county of the 6 sub-counties in Mombasa to be self-reliant. We want them to have all those levels of health services so that we can decongest the referral hospital, Coast General. We do not want it to look at just normal illnesses. You will not go to Coast General unless you have a referral from a sub-county hospital. So if you are in Likoni, you should get all your services in Likoni, unless you are referred to Coast General. And this is what we are trying to do. I think His Excellency the Governor has 2 chief officers now. I am in medical services. I have a colleague who is in public health. And even before she came in, we had started a lot of preventive and promotive healthcare. I think we are the only county who has actually bought 5 latest fogging machines. And we are doing these exercises to reduce. I know you'll say dengue fever just came in the other day. I know, we are still not yet there. But we are saying the community level, the dispensary and health center. Dispensary and community are going to be basic primary health care. Our wish is to actually bring in the family health care physicians to the level of health centers. That is our wish. And we have started doing it. So if I leave infrastructure and I come to, let me say something here. It is not only the county government of Mombasa that has put money into these developments. We have had MSF, Swiss, we have Base Titanium, and we had also Red Cross actually partnering with the county government of Mombasa in this. And we have a very good friend of His Excellency the Governor, and this is Sheikh Al-Falasi from the UAE Dubai, who has actually given a lot of donations, especially in Coast General Hospital. Over 200 beds, 5 renal dialysis, and a lot of other things. In fact, he is now also going to fund low-cost houses in Likoni. So I can tell you, all the time we are being told our governor is flying out, I don't know, even though you see him enjoying sometimes, but he's doing a lot. We have a lot of partners that are actually coming in. The second thing is human resource. What have we done? Professor, we don't employ 2 doctors, I can tell you. We are one of the counties with many, many doctors, over 100 medical officers and specialists in Mombasa. This year, we took 6 last year, and about 2 weeks ago, we took 15 more. So that gives us a total of 21 medical officers. We took 2 dentists. We have enough dental officers. So it's one area that we're very well established. We even have dentists in the health centers, in sub-county hospitals, and even large, high-volume health centers. We have given them dental chairs. Then 6 pharmacists we have taken as well because of the increased services in Coast General Hospital. So oncology, cardiac center, you name it. I think even if you go to Coast General now, they have a pharmacy in theater and even in ICU, so which serves theater and ICU. And we have an HDU, I think, maternal, which I don't think any other referral hospital in any county has done. And maybe let me boast more that we are the first hospital outside Kenyatta National Hospital to have done the first open heart surgery. So I think we are really trying to move so much. And maybe just to say on the cardiac center is we have our own interventional cardiologist, a pediatric cardiologist, an adult cardiologist, and a cardiothoracic surgeon. We have a full team. And a new cardiac center that is open is fully equipped now. And we have a sponsor, the Jaffer Foundation, Mr. Jaffer, the Green Bulk, if you know him. He actually has already started purchasing our cath lab. We should be receiving it around April or May. And I think that would be the greatest thing. That will complete the whole cardiac center for Coast General Hospital. I would want here to actually say thank you, Dr. Swaleh, and the team from Aga Khan Hospital. We are working together with you. We are using the cath lab now. Dr. Mwanzo, our interventional cardiologist, actually uses the cath lab at Aga Khan. So I thank you. And these are the public-private partnerships we're saying. Mombasa facilities, 84% facilities are actually private. It's only 16% which are public. Even though most of the low population of the lower, should I say, low income patients are actually with us. So we take the biggest bulk. But we have to work together. The middle class, the high class come to you. But I can tell you, a lot of middle class are coming to Coast General as well. I don't know whether you've seen that or seen the change, I don't know. On HR again, so what are we doing? We cannot wait for national government where every year you get, like, if you want example, what should I say, a psychiatrist or a plastic surgeon, or very few come out. 47 counties are actually fighting for those consultants. So what have we done? We've done our training needs assessment. We know what we want. We know where we want to go. And we take our own medical officers for specializing training. As we speak, the young medical officer has just come back from Egypt. He's finished his oncology. He's an oncologist. We have a clinical officer that we sent to Moi Teaching and Referral to do oncology, Mr. Adam. And this young man was the one who actually started the oncology clinic with Dr. Ayisi coming from the oncologist from Nairobi. So really, I think we are trying so much. The other thing is towards universal health care, we need staff. If we are talking about quality health services in the lower facilities, and we have partnered with HRH Intra Health Kenya, who have said, put some money, we will put another equal amount and train your people. And not only train our staff, but take young girls and boys who have the qualifications to go and do any health-related causes. And this is called Afya Elimu. So the county has put in 5 million. Intra Health has given us 5 million. And we can take, we already started registering. Example from the Far East, now we want to open that hospital. We are saying those, if we have some young girls from Makirunge, and they have the qualification, we need nurses, we need health records, we need radiographers, so anything that is diploma or certificate course, we are ready to use the 10 million shillings. And this money is not that we are just dishing it out. We are giving it to you on a loan, 4% loan. We will trade you with the money. You come back. You have a confirmed or guaranteed employment. You work with us 1 year free. Then the second year, we start deducting the loan so that that money can be a revolving fund. Finances. I know you've talked about Makueni and all. Mombasa, we are lucky. 30% of people in Mombasa are insured, and mainly from private sectors and all. We have 38% of the population living under poverty line. And I can tell you the other, of course, there's the Linda Mama, there's under 5, which is we don't pay, waived, some dispensed. But let me tell you, you know, in Mombasa, Hatawatu, they keep on telling us, why do we pay in this facility and we don't pay in this other one? The ones that you pay are the old municipal facilities. And we are trying to harmonize. Even SRC has not finished harmonization, even of our salaries. So the salaries are even different, but we are trying to see that all of them do not pay. What we have done in Mombasa, as I say, infrastructure, human resource, we are sending our own to train. We even have 2 doctors who have gone for family physician. One is through the national government in Cuba, and one through the county in Egypt. Linda Mama, yeah, we put 10 million shillings we are registering with NHIF now, 1,600 community health volunteers that we are saying they are volunteering their services. There's nothing we are giving them. We do not have money to dish out as salaries. Like CI, I think CI is one of the counties who has put aside 96 million shillings to actually pay community health volunteers. But they are finding it very difficult. It's not an easy thing to continue. So we put in, and we are telling our community health volunteers, we cannot give you a monthly stipend, but we are giving you an NHIF card. So that when you're sick, but they have to come back and use the government facilities. On quality, I think, as you're saying, the other thing is we have reduced our out-of-pocket. We have our county health accounts. We are working with HP Plus, and we've looked at the beginning of devolution up to now, and we have reduced our out-of-pocket expenditure of the Mananchi from 43% to 34%. And that is all towards universal healthcare. Because, you know, I don't know whether you know this, but there's something called catastrophic expenditure. And that is if a household is going to use more than 40% of their income towards health or non-food, which is mainly health, then that person is going to be more impoverished. We're actually making people more poor because of healthcare. And that is why we need to go into universal healthcare. Thank God Mombasa is not there. We are not among there are about 22 counties that are actually, their line is below or above 40%. So they're actually, their citizens are actually being impoverished because of healthcare. But Mombasa is not in that. I will share that maybe to the chairman later. Maybe just now to say a few things on Makueni, I agree. But let me tell you, Professor, most of the heart is working because now they don't have to pay. They just go to the facility and they do it. I think these are 2 counties, especially Makueni, who has started now for 2-3 years. They are doing very well. You don't have to think of money when you go to the health facility, and that is the main thing, to remove that catastrophic expenditure. The other thing is Oparanya Care. Yeah, they've changed the name now, but it used to be called Oparanya Care in Kakamega. And what they did is when His Excellency Governor Oparanya wanted to come into, he wanted votes in the first year of devolution, before devolution, he told the ladies, the women of Kakamega, I will give you milk. Okay, and you just vote for me and I will give you milk. Because they were always saying, tuna maziwa, hatuna nini, hatuna nini. So actually, they voted for him. And immediately he came in, he just called his health team and said, listen, buy milk for these women. They wanted milk. So they came back, and you know, we are saying exclusive breastfeeding. You're giving milk to the children, and we are saying you should not give milk. So actually, UNICEF came in and did consultancy, and when they looked at the root cause analysis, why are these women wanting, they found that it was poverty. and their maternal mortality was very high, neonatal mortality. So what did they do? They came up with this great idea. They are serving mainly mothers and children. So what they do is they say it is 12,000 per woman.